Hi, and welcome on medical error prevention in a comprehensive integrated system of care. Now, as many of you know, this is a live presentation. Well, go figure. And if you want credit for a live interactive CEU, you'll need to participate in the poll questions. You will need to answer all of the poll questions. So one of the things we're going to do is start out by asking you for your name and your email address. This doesn't go out to the public. It's just so that we can link your name and your email address with your responses so we can prove to your board that you were here and participating. So we will go ahead and go on from here. The first thing that you're going to do is type in your name, your first and your last. So I will give you a little bit of time to do that while I move on to going over the objectives, because I know everybody wants to get to primetime TV tonight. So today, we are going to identify medical errors that are common in a comprehensive integrated system of care, including those systems that look at pain management. Now, most of us who have been working in JCAHO and CARF-accredited facilities know that pain management is just part and parcel of the assessment process now. So a lot of agencies already look at pain management, but we're going to talk about some things that can go a little wonky. We'll discuss how pain influences the comprehensive treatment process, which is why CARF and JCAHO require that we look at it. Identify causes of medical errors, and this is pretty broad. We'll describe effects of medical errors on the well-being of the patient and their family. Identify common documentation and communication errors in multidisciplinary teams. I don't know about you, but I don't necessarily speak the same language as the pharmacist and the psychiatrist and the physical therapist. So making sure that we do have adequate communication and there's not a fear of asking questions and that everything is in one place is definitely something we're going to talk about. We will offer a definition of a medical error as described by the Institute of Medicine. Identify the factors that must be included in a credible root cause analysis. Now, I'm one of those few really strange people. I love writing manuals, and I also love participating in root cause analyses because I think it is interesting and enlightening to hear all of the different opinions about the factors that went into a certain thing. Now, of course, I never like to hear that something bad happened. But participating in the problem-solving process to prevent it from happening again can be very rewarding. And it also can, like I said, be very, very enlightening and very interesting. We're going to identify major signs and symptoms of a medical emergency. One of the things as counselors that we don't train a lot on is preparing for when is something going on that I actually need to call 911. I mean, there's the obvious signs, somebody falls out in front of you. But there are some less obvious signs that we need to be aware of and not take it upon ourselves to differentiate whether it is a panic attack or substance withdrawal or a medical emergency. So we're going to talk about those different situations. We will list pharmacological components of pain management. There's a lot of different drugs that doctors can use to treat pain. So we want to look at some of those and talk about some of the side effects that your patients may experience. And we'll describe other interventions designed to prevent harm and to protect patient safety that's commonly utilized by patients and facilities. So we've got a lot to cover. The state of Florida requires your Prevention of Medical Errors course to be 2 hours. So this part of the course, the lecture, is going to be about 90 minutes. And then there's some reading that you will have available to you if you choose to get CEUs for this course in order to make up your full 2 hours. So now I need you to put in your email address. Just like your name, this is not going to go out to the general public. We need to be able to email you after the course is over in case you decide you want to sign up for continuing education credits. So we can send you an email that will give you a link to the class and the password to get in there and take your test. Moving on. So the first thing we need to talk about is exactly what is an integrated system of care or a comprehensive integrated system of care. That means we have all the different players looking at somebody from a biopsychosocial perspective involved or potentially involved in the treatment of each and every patient, which is wonderful. But a lot of times you have all these people involved and they're just doing their own parallel things here and there and everywhere. And that causes problems because there's a lack of communication. So some of the people that we really need to look at, I mean, of course you're going to consider the psychiatrist and maybe the case manager. But there's a lot of other people that may be involved in this patient's treatment that you're not even thinking about. Psychiatrists, psychologists, physician's assistants, and nurse practitioners, other mental health professionals, physicians, nutritionists, physical and occupational therapists, pain management specialists. A lot of pain management treatment not only is pharmacologically oriented, but it's also oriented around physical therapy. So it's important, if you've got a client who has chronic pain, to ask about whether they have a physical therapist and to work with that physical therapist to identify changes that he or she is seeing. As many of us know, if you have children, or maybe you don't, but you just know, people tend to react differently in different situations. You may have a patient who presents one way to you, a completely different way when he or she is in with a psychiatrist, and yet another way when they're in with a physical therapist. So if we can get all of those presentations and sort of assimilate them, we'll get a better idea of what's going on with the client. And most of the time, it's not because they're trying to hide something or be manipulative. They're actually trying to just give us what they think we want. They think the counselor wants to know about their emotions. The psychiatrist wants to know about their emotions and how the meds are working. And the physical therapist is concerned about their physical comfort. When in reality, we really need to know, all of us need to know all of that. Certified addictions professionals. We know that co-occurring disorders, let me hear you say it now, are the expectation, not the exception. So in a lot of cases, you're going to have people who are seeing addictions professionals or who have addictions issues that need to be addressed. Pastor, religious or faith leaders. A lot of people rely on the support in the community from their spiritual group. And relatives. Relatives. That's one we don't think about too often. Now, Blue Cross and Blue Shield and United and Aetna and all those different insurance companies say that we have to have the significant others involved. But the degree to which we actually do involve them, number one, is somewhat dependent upon the patient and whether they give us a release of information and they want the significant other involved in treatment. Okay, so we got that. But to the other extent, if you have somebody who is the patient has said, yes, I want my spouse or my parent or whomever involved in treatment, to what degree do we involve them? And how much do we involve them in the treatment process with the client? And how much do we involve the client? Which, unfortunately, in my opinion, is very often not enough. We need to ask the client what's working, what's helping you, and let's do more of that. Even if I want you to do this thing over here, we know from motivational enhancement therapy and all the other research, what matters is what the client feels is working. So we need to consider not only all of the people that are currently involved in our patient's care, but when we do our assessment, we need to say, are there other people that we might be able to involve who might be able to contribute something useful to this clinical picture? It may just be a consultation. You may not be referring out for a full, you need to go to physical therapy for 3 months. But it's important to consider all your different avenues. And one of the things that I didn't even put on here are your caseworkers, your case managers, and your caseworkers that work at the different social service agencies. You may need to reach out and communicate with them or help the client reach out and communicate with them in order to meet their basic biopsychosocial needs. All right. So one of the first questions I have for you are, what are some common errors, medical errors specifically, or problems that you see, and what effects do those medical errors have on your patients and potentially your patient's family? Okay, so in some cases, Agencies really want us to focus on billable units, which may lead to rushed client care, overbooking, and poor documentation. I don't know about you, but I despise going into a doctor's office and having to wait. Now, 5 minutes, 10 minutes, that's one thing. But if you're waiting 20, 30, 40 minutes because the doctor overbooked, that gets a little bit ridiculous, and it makes you want to not go back to the doctor or the dentist or the veterinarian or whomever it is. So it's important to realize that not only does that affect the patient, but they're going to go back and tell their friends, oh my gosh, I would rather just suffer through the pain than have to go sit and wait. Pressure to treat all patients who present regardless of appropriateness. So you may have patients who come in who would benefit from a different type of care, or who may not be ready for the particular level of care that you offer, but there's pressure, again, more on the census than what makes sense. So that's another thing that you need to look at from a medical error perspective. If you put somebody in an inappropriate type or level of care, it's going to probably backfire. Insurance restrictions, preventing the use of case managers and leaving counselors to do case management activities. This was one of our greatest frustrations at the residential facility I worked at, because we'd have people who needed to get back on their feet. They needed to engage with social services. They needed to find housing. They needed a bunch of different liaison activities. And we weren't able to hook them up with case managers unless they fit this very, very narrow profile. So a lot of my staff had to do the case management activities in addition to counseling. Staff being too tired or sleeping on duty. And when we get down to root cause analysis, we'll really talk about some of this. But some of that goes to organizational and staffing issues. If you have sleeping on duty, I know one of the big reasons that I've observed is people who work the midnight shift or who work the evening shift are generally, that's their second job, because either your job or their other job is not paying them enough. Not that we can necessarily solve that, but we need to, again, look at what's causing that and what's the impact. If a staff member is sleeping on duty, then they are not providing client care, which means clients have a lot more opportunity to get hurt. And staff being, whoops, where did it go? Staff being asked to do things outside of their skill set. There are certain things that ethically I can't do because I haven't had the advanced training. I do not feel comfortable seeing small children because I wasn't trained in play therapy. I wasn't trained to work with small children. But according to the licensure laws, theoretically, I'm able to see small children. So there was always a pressure from up above, if you will, in certain circumstances to see people that I didn't feel like I was as competent to do the assessment or to do the treatment. So those are things that can lead to errors, because if I'm not competent, which I don't think I was, then if I would have seen a client, chances are my assessment may have been off the mark, which would have led to more problems. Caseloads being too large. Again, this is partly an organizational thing. Actually, it's more organizational than anything. We'll talk about in root cause the difference between organizational and institutional. But the organization often wants to increase billable hours and make sure that you have a certain amount coming in, which makes it difficult to serve each patient effectively. Again, because a lot of times you're having to do things that you can't bill for. I know as a therapist, I wasn't able to bill for case management activities. So all of that stuff, which probably took twice as much time as I spent doing counseling, I couldn't bill for. Was it necessary? Of course. Was I going to skimp on it? Of course not. But then my stats would go down. So there's always a balance and always a stress with whether your caseload is large enough and what you need to do to make your billable units. Not communicating with medical doctors. Now, I've seen a lot of reasons for this. One reason being the doctors don't feel like they have time for you. One of the things I took to doing was writing up a synopsis for the physician if there was an issue, empower the client to talk with the physician, but also put that in the case notes. That way it was clear that there was communication back and forth, and we always had to initial the physician's notes. The other thing is doctors not being available or clients refusing to sign releases of information for doctors that are outside of your agency. So there are reasons you may not be able to communicate with them, but those can lead to medical errors, and we need to figure out how to navigate that. Caseloads being too large, not trained properly in all areas. One of the areas that I'm finding people don't feel comfortable with that they're expected to do right now is their electronic health record. It takes inordinate amounts of time to try to get that stupid thing to work. And I'm just speaking in general about EHRs. You know, I've experienced 3, and one has been really good. One made me want to pull my eyelashes out. So there are differences. Counselors asked to hand out meds when the nurse is not available. Now, this is always a tricky thing that's going on, and we'll talk about communication in a little while. Again, that was one of my big frustrations when I was working in residential, because all of those abbreviations they use in the medication administration record, or the MAR, I'd forget those. I didn't use them daily. So BID, TID, QID, I'm like, I don't know. Trying to interpret what was going on and how do you handle it if a client cheeks medication, refuses to take it, etc. Because where I came from, we couldn't administer the meds. We had to watch while the patient took their own meds. But still, there was a lot of information that you had to be processing and taking in. So yes, that leads to a lot of concern about medical errors, if not medical errors. Okay, wow, that was an excellent set of responses. Oops, sorry. Error causes. Multiple professional involvement. So too many cooks without a chef. If you've been involved in a multidisciplinary team, and I've been involved in good ones and bad ones, not that the professionals were bad, but that coordinated and uncoordinated, I guess, would be a better way to say it. You've got all these people who have all these wonderful points of view, and they're all running in 6 different directions. That doesn't help the patient. There needs to be a single point of contact who assimilates all the information and helps us keep track of what the right hand is doing and the left hand is doing. So that can be a cause of errors, especially if you're dealing with professionals in different agencies. In your own agency, you can go pull the chart and see what happened. But if you're referring to different agencies, even if you have a release of information, getting timely communication may be more difficult. One of the things that you can do is set a time for a weekly conference call or a monthly conference call, or set some sort of procedure that you follow when you're working with external agencies. Misdiagnosis or assignment of false diagnosis, and this is kind of 2 different things if you think about it. Misdiagnosis, in my mind, is something that you do unintentionally. You diagnose somebody with major depressive disorder when they've actually got bipolar 1. Okay, that's a misdiagnosis, and it has its own whole set of problems because the medication for major depressive disorder and bipolar 1 are different, and antidepressants can trigger a manic episode. So that would be one medical error if that happened. Assignment of a false diagnosis is, in my mind, more intentional, where you're saying, okay, well, this person really, they've got an adjustment disorder, but insurance won't pay for that, so we're going to bump it up to major depression. That's a medical error in billing. It hurts the insurance company, which, you know, some of you are going, oh, poor things. But that also comes back on the patients, raises insurance rates, yada, yada, yada. It also may follow the patient. If you've got a patient who is in a safety-sensitive position, having a diagnosis of major depressive disorder or bipolar could really come back and haunt them if they go for some sort of a security clearance or something. Now, we would hope it wouldn't, but the reality is sometimes it does. So we want to make sure that what we're assigning is what the patient has. One of my biggest pet peeves is when I'd go back through a chart for a patient who'd been with us for a while, you know, in different episodes of care, and every episode of care there would be a different diagnosis, and I'm like, okay, we're missing something here. This person is not swapping diagnoses. We need to get a bigger picture of what's going on. So that goes back with communication as far as preventing misdiagnosis. If you have the ability to look at prior information, that's going to be really helpful. Now, some people don't like to read the chart before they go into the assessment with the patient because they feel that it colors their interpretations of things, and that's fine. But before you make your final diagnosis, it's good to get other points of view from what other professionals have seen, from collateral resources. So misdiagnosis can be a problem because we give the wrong treatment, and assignment of a false diagnosis can be a problem, and it could go the other way. Let me clarify that. Sometimes, because a person's in a safety-sensitive position, they're like, well, you can't put down that I've got bipolar. Just put down that I'm depressed. That's, again, going to be a problem because the treatment is very different, and it could cause potentially some legal ramifications. Intimidation is another cause of medical errors. And a lot of times this happens in multidisciplinary teams when one agency or one agent from an agency feels or gives the impression that he or she feels superior and that their way is the only way, so don't question it. I've been very blessed to work with a variety of different medical directors and a variety of different clinicians, and they've all been very open-minded to, okay, let me hear what you're seeing. Now, they felt very passionate about their point of view, but that didn't necessarily mean that we couldn't have a discussion about what was going on. Overtreatment, and I talked about this a little bit earlier. If you take somebody who really only needs, you know, twice a week counseling and you put them into intensive outpatient, the patient is most likely going to drop out because that's way more treatment than they need, which means the likelihood of their symptoms exacerbating and them relapsing, mental health or substance, is highly likely. So you've created a scenario where the patient is almost destined to fail, which is the opposite of what we're trained to do. I mean, basic ethics, above all, do no harm. Don't set your clients up for failure, regardless of your reason. Relaying false client or patient information or your own personal information. So if you relay false client information about their diagnosis or how often they're coming or how long they stay. One incident that I became aware of was a clinician who had intensive outpatient group, which is 3 hours, and he would not note in the chart if a patient came late or left early. So he was billing the insurance company for the entire 3-hour period, even if the client came late or left early, which doesn't work. And relaying your own personal information falsely, saying that you're licensed when you're not, well, that's like, you know, criminal. But also communicating personal information such as what your expertise is, or glorifying something, your training in some area where you may not really have that much training. Inappropriately sharing or distorting information, sharing information with others without a release of information, even if it is, in your opinion, in the client's best interest, if it doesn't meet one of those criteria that allows us to break confidentiality, it's a medical error. And it causes the client to go, really? So I can't trust you to obey, you know, federal mandates. That's not a good foot to start on. One example of this is if you're working with a patient who you can see has a problem, you really believe in your heart of hearts has a problem, And they're not willing to see or willing to act on that yet because they're in pre-contemplation on that problem. And instead of meeting them where they are and trying to address other issues or make some sort of a game plan and step them up incrementally, calling an interventionist and saying, hey, I've got this patient named Jim Bob, and I would like you to come meet with him while he or she is in our detox unit and see if you can convince him to go to treatment. Oh, that's just bad on so many different levels. The patient feels ambushed. The patient loses faith that their confidentiality is being maintained. It's a HIPAA violation. The patient's family feels like they've been hit from out of the blue because the patient's like, no, I went there and they started trying to coerce me to stay. So it's really, really important that when you're making referrals, you get releases of information. You talk with the patient before you do it. You don't want to have another professional come up and say, oh, hi, I'm so-and-so from such and such, and I was informed about your situation. And the patient goes, excuse me? Even if you're working within the same agency, it's good form to talk with the patient ahead of time and say, you know, I really think you would benefit from talking with our case manager or our medical director or whomever the case may be. Would it be okay if I set that up? Empower your clients. Don't take away their power. Don't make them feel like they're being blindsided. If you don't consult with medical professionals, you just kind of assume everything's okay. Or something's a little wonky, but you know, you're going to let it ride. No. Think about all the different medical issues that people may have that mimic mental health issues, or the side effects of medications that they have that may mimic mental health issues, and vice versa. So if you have somebody who's talking about chronic pain or headaches or whatever the case may be, or depression, ask them if they've had a physical recently. Let's rule out some of the really obvious things first, like hypothyroid, hyperthyroid, hormonal problems, polycystic ovarian syndrome. Let's rule out some of those diabetes, that we know we can treat and maybe provide this patient some relief quicker. Not thoroughly collecting background histories or complete assessments. Not asking what's worked in the past. If you went into treatment and, you know, you did your thing and maybe you had a good stint for 6 months where you were feeling good, and then you relapsed and you went back to treatment and you had to start at the beginning again and do all the same stuff that you did the first time. Okay, the first time you may be able to let that pass, but in your 3rd and 4th episodes of treatment, you're going to be going, really? I already told you this didn't work. So then the patient loses faith. They're like, I go back there and they tell me to do the same daggum thing that didn't work the first 4 times. So we need to ask them what's worked, what didn't work, what can we do differently. We need to collect background histories about their physical health and what's going on. Again, physical health can change. That's why we have physicals, supposedly, annually, because things can change. And it's important to be able to help patients understand that there are certain physical situations, I don't want to say maladies or illnesses, situations that may lead them to feel worse that can be easily treated. I know my daddy was just the worst. He put off going to the doctor forever. You know, it was like 10 years between his first and last checkup. And I'm like, really? Because he would rather do anything but sit in a waiting room and be poked and prodded and treated like a lab rat. Medical error. We don't want people to feel impersonal. We don't want people to feel embarrassed or apprehensive or frustrated. Because my daddy, I said it was 10 years. Well, that was 10 years that his melanoma grew. And by the time he actually went and had it identified, it was stage 4. Too late. So, you know. I don't want that to happen to people, whether it's melanoma or suicidality or addiction. Let's let people feel like they have a say and they're empowered and they can actually go to somebody and get some help. Providing inadequate safety or security of the physical environment, that kind of goes without saying. If somebody feels like they're walking into the middle of a dangerous situation, they're probably not going to go back. And it doesn't even necessarily have to be dangerous if they walk in and it's gross. I've mentioned in other presentations I'm a freak about baseboards. And if I walk in and there's dust and nasty stuff all over the baseboards, and if it smells raunchy, chances are I'm not going to go back. Because your appearance and your outward presentation says a lot about how much you care about things. Now, you can be in a really old building, but if it looks like you're at least trying to take care of it, that's all that matters. Maybe you're spending a whole lot more time with patients. That's great. But remember that patients will form an opinion, and that will impact their perception of everything that happens henceforth. And recommending inappropriate or dangerous treatment protocols. Informed consent. That's all I'm going to say about that. Make sure your patients know that it's experimental and what the risks and potential benefits are. Medical error effects. Loss of trust means the patient may drop out, or they may be there in body but kind of not in spirit. They're like, okay, I've got to sit here for the next 8 weeks, but you can darn well be sure that I'm not going to tell you anything because I don't trust you further than I can throw you. Which means likely their symptoms will worsen, whether it's addiction or mental health, and it will lead to some sort of a relapse. So then they look back and they go, well, I was in treatment. It didn't do anything for me, so why should I try it again? Making sure patients know going into it what the limits on confidentiality are. Doing what you say you're going to do. And keeping them apprised. That whole informed consent, one of my big spiels when patients first come is every therapist has a slightly different style. And you may connect with one but not another one. And that's not a personal statement necessarily about any one clinician. It just means you connect better. So if you don't connect with me well, let me know what doesn't feel like it's working, and we'll work on that. And if I can't fix it, then I may refer you to somebody else. I am a very action-oriented, cognitive behavioral type person. And if you're looking for psychoanalysis, we're not going to be a good match. I make sure that people understand that going into it. It's not going to offend me if you say, you know, this doesn't feel like we're doing anything here. I'll ask you what might help you better. So we need to help clients understand that mental health treatment, just like any other treatment, but even more so in many cases, there's something of an art to it. And just like not everybody likes Picasso, not everybody is going to fit with you. So they need to feel comfortable articulating that and identifying what it is that they need. They may lose trust that accurate, complete information will be passed on to other providers. If you make a referral and they get to that referral place and the referral's like, I've never heard of you, the patient's going to get a little irritated. Or if you don't give complete information. If you have a referral source that sends a patient to you, you need to communicate as much as you can within HIPAA guidelines, yada, yada, yada. But a lot of patients want you to communicate with that person so they can get off probation or get their license back or what have you. And if you fail to do your part, the client is likely going to feel sort of bitter towards the entire profession. Reversal or relapse of their condition. Patients taking incompatible medications due to lack of communication by various providers. An example, some dentists are now trying to prescribe antidepressants for people with TMJ. Well, you know, I'm not going to get into that right now about my feelings on that, but I will say enough to say that if they don't consider, or at least first ask, what other medications a person is taking, they could prescribe an antidepressant to a patient who's already taking an antidepressant, or worse yet, a tricyclic antidepressant, and cause a really significant medical error. Serotonin syndrome, overdose, who knows? And a lot of patients don't think to ask, well, how's that going to interact with these other 6 things that I'm taking? So it's important that before providers prescribe medication, they actually not only get an inventory on the assessment of what medications the patient is taking, but read it. So making sure that you know what your patient is on. Patients abusing medications or taking inappropriate medications when multiple causes for emotional or physical pain are not considered. If a patient comes in, and we'll use back pain for an example, because that's a common one, and a patient comes in and says they've got back pain, and you say, oh, okay, well, you must have strained your back, so we'll send you to a physical therapist. Or maybe it's their general practitioner and the GP just writes a prescription for a muscle relaxant. If the back pain is caused by something else, maybe not kidney disease, but kidney infection, thank you. It's late, you know. It could be a very different diagnosis and a very different medical treatment, and not treating the kidney infection could lead to complications. From an emotional perspective, like I said earlier, there are a lot of physical conditions that have emotional symptoms. Thyroid problems, it could just be a thyroid problem, or it could be thyroid cancer. But if you've got a patient who says they suddenly started feeling really depressed, one of the things you want to ask them is, let's look at all the reasons or all the things that might produce these types of symptoms. What medications are you on? What has gone on in your life? You know, that's what we ask. Have you had a blood test recently to check your blood sugar and your hormones and your thyroid and all that kind of stuff? Let's not just assume that the patient is feeling depressed because it's an emotional cognitive issue. When we don't treat it, or when we treat it inappropriately, they're not going to get relief, which means they're going to start trying to find something on their own to make the pain stop, which leads us to abusing medications or taking inappropriate meds. Losing important wraparound services due to poor team communication or lack of necessary paperwork. If you don't do the referral, or where I came from, temporary aid to needy families, it was called TANF. And there were certain forms that you had to fill out on a monthly basis, and certain things that had to be in their treatment plan in order for them to qualify for payment of services. So if those things weren't done, it could negatively impact the client. Now, most often it negatively impacted the agency, who just didn't get paid for the services. But that happens enough, then the agency has to lay off staff, and then you can't serve as many people, and it hurts the entire community. You see the ripple effect. Okay, enough on that soapbox. Losing family support if psychological and financial assistance is withdrawn or reduced through lack of follow-up with insurance or completed recommendations by any team members. What does that mean? That means if the family perceives that the patient's situation is hopeless, or if the family perceives, even worse, that the patient isn't doing what they're supposed to do, when in reality it's the provider's not doing what they're supposed to do, the family may back off and go, well, when you do your part, we'll do our part. And the patient's going, I did my part, but my therapist didn't, or my physical therapist didn't, or my doctor didn't. This is really true when it comes to filing disability claims, but also getting your license back and other things. So again, it's important that we keep our promises, we do our paperwork. It doesn't have to be glorious. It has to be adequate and towards the better side of adequate. But we need to do what's in the best interest of our patients. Clients may lose the ability to feel psychologically or physically safe with us or in their own environment. If we are working with a client who has domestic violence issues, and we are not providing the resources and the referrals and the assistance that he or she may need, then the situation that they're living in may get worse. Likewise, their mental health situation may get worse. They may get to the point where they're suicidal or homicidal, and that could have been prevented by effective early intervention. Medical error. Patients may experience anxiety about new or particular environmental settings and/or the introduction of new professionals as well as treatment protocols when proper protocols are not followed or referrals made. Patients who come in, and I had this happen to me recently. I went in for a physical, new physician, and I asked at the front desk when I checked in, I wanted to make sure that all of my lab tests were going to be sent to a participating provider that was covered under my insurance. And she assured me, yeah, no problem. We send them all to a lab that your insurance is in network with. And I said, great, wonderful. Did my paperwork, went back there. No sooner did I sit down, the doctor starts handing me these other forms to fill out, acknowledging that this test and that test aren't covered by my provider and will be sent to an outside laboratory. Really? No, I just covered this. What's the point of going to an in-network provider and asking these questions if you're going to end up having to, and these were normal tests, like vitamin D tests and stuff. It wasn't like I was having something weird done. So it's important to be upfront with your patients and not try to pull things kind of slipshod as they go. Going to situations, I know a lot of people have dental anxiety. So if they have a bad experience with a dentist or with a doctor, they may be nervous about going to another one. So it's important to explain what may happen and to make it as positive and empowering experience as possible. Clients may place themselves in unnecessary physical or emotional danger because of their inability to use sound judgment or their unwillingness to seek treatment, like my daddy did. He didn't want to have to go and be poked and prodded and treated like a lab rat, so he didn't, and something that could have been treated progressed. I've known a lot of people who've done that, where it's just too much of a hassle to do this, or it's, you know, I know I'm going to have to go and sit and wait for 2 hours because the doctor has no respect for my time, or blah, 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 blah. These are the excuses that I hear a lot, and sometimes the ones I say. I don't like sitting in a waiting room. I don't like being treated like a number. So it's really important that I don't do that to my patients. And I would rather have a 15 or 20 minute gap between patients than have them double booked any day. Effects can also mean worsening existing or creating new physical or mental health conditions. Self-explanatory. Patients may experience trauma as a result of a medical error, which can cause mental health clients to develop acute stress issues. So if there's a medical error, a physical error, that causes them maybe to land in the ICU, that can increase their anxiety because of this near-death experience. Then they start questioning everything. If it's a mental health provider that makes the error and maybe doesn't prevent a foreseeable suicide or take steps to try to prevent a foreseeable suicide, then the client may also, or the client's significant others, may develop acute stress issues if the person obviously doesn't complete the suicide. Taking unnecessary personal risks, we already covered, and causing harm to self or others. One of my beliefs, many of them, is that people do the best they can with the tools they have at any given time. And at a certain point, if a patient has gone to their physician and not gotten relief, they've gone to a physical therapist and not gotten relief, they've gone to their preacher and not gotten relief, they've come to their mental health counselor and not gotten relief, guess what? They're going to try to find something that's going to be relief. That can be addiction, that can be drugs, it can be alcohol, it can be self-injury, it can be a lot of different things. Or it could be eliminating the source of their stress, i.e. homicide. So we need to be cognizant of the intensity of the patient's condition and whether it's getting worse or getting better, and really work on a strengths-based perspective to help them identify what is it that we can do to help you right now so the pain can at least subside a little bit. I may not be able to make it stop, but what can we talk about? What things can we brainstorm together that you may be able to do to make the pain subside? So documentation and communication errors in multidisciplinary teams are many. Shorthand and really bad handwriting. If the notes are illegible or unintelligible, then they're useless. So try not to use shorthand, or at least use shorthand that everybody on the team understands. Poor communication between teams can be a result of documentation quality. Having crappy documentation leads to crappy communication. Or poor content, and you're not getting enough information from the patient, you're not getting enough information, you're not synthesizing the information, you're just getting it all and stuffing it into a folder, and nobody's actually looking to see what the right and left hand are both doing. Lack of a single point of contact. This is the person who assimilates all the stuff that gets shoved into the folder and disseminates it. Doesn't do any good to assimilate it if it doesn't get disseminated. The single point of contact is crucial. And it doesn't mean that person is any better or any more important or anything. It just happens to be who is tasked with making sure that all the referrals are followed up with and all the documentation is collated into the file and that everybody is on the same proverbial page. HIPAA violations. Faxing to an office without making sure you're sending to a secure fax. That's a HIPAA violation. A lot of times patients don't find out about it, but it can be a big problem. Calling like the patient's physician without having a release of information. One of the things I do with my patients is that's one of the things that we fill out in the initial assessment, and I explain to them why I really need a release of information to talk with their physician. 90% of the time, the patient has no problem signing it, and then I can just communicate what's needed with the physician. The other 10% of the time, if the patient really resists, since I work with patients with co-occurring disorders, my first reaction is, okay, red flag. If they don't want me talking to their doctor, I'm wondering why, what's going on. A lot of times they're not willing to share that yet, but it's something that I will file in the back of my mind. Making assumptions without clarification or confirmation. You see a patient who's taking 6 different medications, okay? Anti-anxiety medications. Maybe they're taking a benzo. What's your first assumption? Why are they taking it? Anxiety? That'd be my first assumption. But it could be for chronic pain. So that's something we need to ask about. Why are you taking this medication? If the patient doesn't know or doesn't know their dosage, again, a red flag that you want to look at. Having the patients have full understanding of the medications they're taking is also important in my mind. So sometimes I'll have patients that are taking antipsychotics and they don't even realize it. They're like, oh, that just helps me sleep. Do you realize that this is a pretty heavy-duty med? We'll talk about what the medication is. You know, it may be a perfect assignment for them, but I want them to be aware of what the medication is, what the potential side effects are, so they can just be aware and be informed. A lot of times the patients are very happy with what they're taking, and it's far be it from me to question it, but they need to be informed. And looking at the causes of their pain or distress, we want to clarify, we want to confirm. If a patient says they had a bad accident 6 months ago, And that's why they're taking all of these painkillers? Okay. Well, we may need to confirm that. You know, I want to talk to your doctor so I can see how we can help you with maybe some stress management or progressive muscular relaxation. Because I would. You know, that's not a story, but I also want to confirm exactly when the accident happened. Why? Well, in a car accident, you could have back problems, but then you also could have some brain trauma that may not show up until later. Ask questions. Get a full clinical history. So what are some common concurrent issues you see with your patients who have chronic pain? Lack of energy. When you have chronic pain, at least when I have chronic pain, I don't sleep very well. I sleep a lot, but I don't sleep very well. So I always feel tired, but I always feel like I haven't gotten anything done because I'm sleeping all the time. And pain medication, at least for me, makes me really tired. Irritable all the time. Again, when I'm in chronic pain, I tend to be a little bit more irritable than I normally am. A little high-strung. But patients who have chronic pain, who have increased irritability, think about how that affects the relationships with their significant others. Eventually, it's going to start grating on things. So we need to look at helping them address this issue so they're not as irritable, because I don't think anybody wants to be cranky. It wears them down until they feel hopeless. Wake up every morning and it hurts to move. Try to do things that you love to do and you can't do them because the pain is too great, or because your hands go numb, or whatever it is. These are things that you need to address. I know one of my biggest frustrations right now, I used to love to do cross stitch and needlepoint, and I cannot hold a needle for longer than 2 or 3 minutes now without my hands going numb. Can't do it anymore. So I'm trying to teach my daughter how to cross stitch, and it's frustrating. You know, doesn't cause me a great big deal of issues, but if it really significantly impacts somebody's life, it can be a problem. They may become snappy with their peers. My grandfather in World War II was on a boat that got sunk, whatever, a big metal thing hit his head, cracked his skull. They put a metal plate in. Now, this is back in World War II. So you can imagine that technology wasn't so wonderful. Poor man had brain injury and was in chronic pain for the rest of his life. And yeah, he was irritable. But now that we look back in retrospect, we go, oh, silly us. Maybe he had a reason to be cranky. Because we weren't addressing the pain. They were giving him antidepressants, which, you know, helped a little bit, but it still didn't make the pain go away. People who have chronic pain may not be able to exercise as much or the way they used to, which may lead to weight gain and other cascading issues. I love that commercial for one of the arthritis medications. A body at rest tends to stay at rest, and a body in motion tends to stay in motion. Not all of our patients can do that. So we need to help them figure out how they're going to get their blood moving and how they're going to feel good about themselves if all of a sudden they find themselves paralyzed or on bed rest or whatever. How are they going to keep their energy up? You don't realize until you're on bed rest for like a week or more how tired you can get by sitting around in bed all the time. It's really important to make sure that our clients understand that it may not be a mood issue that needs medication. We may need to do some things differently and see if we can get you in a change of scenery. For me, when I was on bed rest with my daughter, it was getting outside and getting some sunlight because I can't stand to be inside in the darkness all the time. For our patients, that may help. It may not do everything. But let's brainstorm some things that may help them feel better. Let's work with their physician and their physical therapist, that communication and the multidisciplinary team. Yeah, and say, what might help Jim Bob feel a little bit better? They have a hard time maintaining a life and schedule because they don't know when they'll feel up to it. People with fibromyalgia, that's one that I've worked with a fair amount, so I can speak to that. they don't know if they're going to wake up and just not be able to move because it hurts too much. So they don't want to make plans, which eventually impacts their relationships because people feel like they can't count on the patient. And the patient feels bad, and it's just this really negative cycle. So we need to talk about what's realistic. We need to talk about educating. Remember, in that comprehensive list, we did have relatives and social supports. We need to educate them about what the patient can and cannot do and how they can help and how to navigate this a little bit. It's really hard with children because children don't necessarily always get it the same way adults do. But it's important to try to involve the entire support system in the recovery process if you're able to. Okay, so helping people figure out what's worked to help them feel better in the past. Hesitant to talk to medical doctors because they think people are pill shopping. Oh my gosh, let me tell you. When we were in Florida, which unfortunately is now thought of as the pill capital of the world, you could get reasonable amounts of medication, you know, like 30 pills of a muscle relaxant or something, and the doctor wouldn't freak out if you were doing it, you know, once every 6 months. If you go to a doctor in Tennessee or in Virginia, they look at you like you've lost your mind if you ask for the same thing. And then you have to sign all this paperwork that says you will not sell it and will not do this. And I'm like, well, if I was going to sell it, that's illegal. So why would I care about this paper I'm signing? But okay, I digress. It has unfortunately come to that situation now where the powers that be have started regulating doctors so much and put them under so much scrutiny that people who have real pain issues or real back issues or whatever have a hard time getting the basic medication they need, you know, for 2 weeks or 30 days. So that is a concurrent issue because, again, people don't feel not appreciated. They don't feel empowered, and they feel like they're being judged if they're asking for what they need. Really? How dare we? And counselors, not so much because we don't have the power of the pad, but we do, to a certain extent, need to be careful of how we come off to clients and whether clients feel like they're being empowered or they're being judged. So, pain. More than 50% of patients with pain have concurrent depression. Interesting thing. Sometimes depression is somaticized and people feel pain because of the depression. It hurts. If you've ever been so depressed it hurt to move, you know what I'm talking about. But there's also people who have pain and can't get out of bed, can't do what they want. They're grieving the loss of the life they used to have. They're not sleeping well. They're irritable. Nothing seems fun anymore. Oh, does this sound like the symptoms of depression? Hey! So we need to look at what's causing those symptoms. Do we have all this negative cognitive stuff going on? If so, we can address it. Is the person not sleeping well? Are they not eating healthfully? What things are they willing to work on to address their depression? Figure out what they think is causing their depression. Pain assessment and management techniques. We need to know the type of the pain. Is it a shooting pain, a stabbing pain, an aching pain, a burning pain? I got real good at these pain assessments. The duration. How long has this been going on? Is it a week? 6 months? On and off for the past 10 years? Help me understand. Frequency. Constantly? Once a month? What are we talking here? It doesn't mean if it's only once a month or once every 6 months, it doesn't mean it's any less detrimental. but we need to understand how often it occurs so we can start trying to figure out what's causing it. Intensity. Is it just a nuisance or is it debilitating? What are the exacerbating factors? What makes it worse? And the mitigating factors. What can you do that makes it better? Get all that information. That'll give you a good idea. Then you can start charting what's going on. Now, if you have somebody who's coming in and they've got chronic pain, good idea to refer them to their GP if they haven't had a physical in the past 6 months. Rule out anything that the GP may be able to help with. Medication may help, may not. Physical therapy may help, may not. Stretching, stress management, ergonomic assessment. If you're sitting at a workstation and you're hunched over like this and you're typing, and as the day goes on and your stress goes up, your shoulders go closer and closer to your ears, medication's not going to make that go away. Part of that is an ergonomic assessment and being aware of your posture and where you're storing your attention. Stress management may help. I mean, medication can help once the muscles are spasming, but it's going to keep coming back. So you're not really solving the problem. You're just kind of putting a Band-Aid on it. So ergonomic assessments can be important. If somebody stands all day long or walks all day long. If you walk all day long, well, some people are used to it. I cannot walk all day long in high heels. My back, I feel like I'm walking around like a 60-year-old woman. So it's important to ask them, are there days when the pain's worse, and what do you do differently those days? Write it down. Because people may be afraid to talk with their doctors or may feel like they're imposing or have this whole white coat syndrome, my grandmother does. She walks in and she's like, yes, sir, yes, sir. And we're like, Grandma, you didn't tell him anything. You want to make sure that you give them something that they can give the doctor. This is a checklist of the symptoms that I've got right now. If they choose to give it to the doctor, great. If they don't, that's on them. But at least you've given them another tool if they get all flustered in front of a white coat. We need to understand how pain influences comprehensive treatment. If people are in pain, treatment compliance and motivation may go down if they don't feel like it's making the pain go away. They may self-medicate with alcohol, opiates, Tylenol, but to a point where it's detrimental to their health. It can cause problems that mimic anxiety or depression. And it also may cause anxiety and depression if you're grieving about the fact that you can't do something anymore. It could, throw you into a depressive episode. We need to consider these things. Sleep disturbance. Already talked about that. So pain, somebody who's in chronic pain, and I talk all the time about Maslow's hierarchy. If we're not addressing those medical and basic physical needs, we may be undermining our entire process because we're not setting a good foundation. Pain medications, and there's a whole list of them. I'm sure I've missed some. Non-steroidal anti-inflammatories like Relief. Patients can take those. Patients can OD on them. Patients may not find relief. Excuse me. Corticosteroids. These are anti-inflammatories that are usually given at the site, either through an injection or through a cream. Sometimes they're taken orally, like prednisone. Prednisone, most people that I've known who've taken it hate it because it makes them feel hungry and bloated and just, ugh, which doesn't help a lot with your mood when you feel that way. You like my clinical term? Tylenol, one of the most often overdosed on drugs because people don't look and see, oh, I'm taking Tylenol, but I'm also taking NyQuil that has Tylenol in it. Opioids, well, we all know what those are. And they can help, But generally, opioids aren't doing anything to deal with the pain. They're just blocking the pain reception. Muscle relaxants may help. But again, we've got to look at what's causing the muscles to spasm. Is it an injury? Okay. So make the muscle stop spasming until it's healthy. Great. If it's stress, muscle relaxant, you know, it'll work for an hour or two, and then you're going to be in the same position again. Benzos, your anti-anxiety drugs. They actually help with stress-related, so people who are like this, it doesn't deal with the source of the stress, though. So if the person stops taking the meds, the pain comes back. Not really helping the person there. Some antidepressants, especially the tricyclics like amitriptyline and nortriptyline, have also been found to be somewhat effective in helping with pain, especially neurologic type stuff. As are anticonvulsant drugs, especially as they relate to neurological problems like Tegretol, Neurontin, Trileptal, Lyrica, and Topamax. Now, I'm not recommending any of these. These are just the ones that, you know, I know I commonly see in charts. The anticonvulsant drugs I've seen most often in people who have things like fibromyalgia, and in people who are in recovery from addiction, especially from opioid addiction, who don't want to take opiates. A lot of times I've seen docs prescribe that instead. Other things that can be done for pain: hydrotherapy, TENS units, massage, acupuncture, if you're okay with that. Acupressure, I'm good with that. No needles. So there are a lot of alternative therapies that we can look at that can help where the medication leaves off. Pain, errors, and multidisciplinary treatment. If we ignore reports of worsening pain or lack of relief, and I'm going to pick up the pace here a little bit because I want to make sure I have you out of here by 7:30. Failing to address disability-related grief and adjustment issues. And I've talked about that a couple times now. I'll give you another example. My grandpa, the one who had the plate in his head, towards the end of his life, he developed Parkinson's. And what he had always done, you know, he was agitated and he had a hard time concentrating. So most of my life, I remember him sitting at the end of the dining room table and reading or whatever. Then when he got to the point where he couldn't read anymore because his eyes were bad and his hands shook too much when he tried to hold the paper, he started, well, I guess somewhere in there, he started building miniatures. Towards the end, that's all he had left that gave him pleasure. And when his Parkinson's got to the point where he couldn't do that anymore, his depression just went through the bottom. Addressing those issues. And interestingly with him, right about that time he was put in hospice care. And after about 6 months, he was still in hospice care. And the doctors asked him kind of what was going on and stuff. And my grandmother said, you know, you act fine until the nurse comes. And then all of a sudden you seem to get worse. And he says, yeah, because if I get better, they'll stop coming. Addressing those psychosocial needs. I mean, my grandmother's a lovely woman, but Grandpa enjoyed having other people come in and be around, and he didn't have the ability, because he was agoraphobic on top of everything else at that point, he didn't have the ability to go out and experience other people. It stressed him out too much. So we need to look at what's going on with these people. What is it about their quality of life that has changed, that is most meaningful to them? And how can we address it? Having volunteers go in and talk to him would have worked wonders too. And by the way, after they terminated his hospice treatment, he lived for like another 2 years or something. I mean, he was a stubborn old man. But we figured out what it was. And so, you know, people started rotating in through a little bit more. Instead of thinking, well, we want to let him rest, it was just the opposite. So we were assuming, without checking in on our assumptions, we were assuming that he wanted to be left alone. Attributing mood changes to psychological factors instead of medication. If somebody's mood drastically changes, it may be psychological stuff, but it also may be they started taking alcohol or opiates or ecstasy or bath salts or whatever the going thing is. Ask about it. A lot of times your patients will tell you. Mood changes could be due to sleep disturbance, and it may not be because of chronic pain. It may be because they moved into a new house, or they just got a new bed, or they just got a new pillow. If you're as attached to your pillow as I am to mine, you'll understand. It can be a big deal when you don't have your right pillow. So ask what's changed, because sometimes people don't realize that, oh, I didn't realize that, yeah, you're right. As soon as I got that new pillow, I became kind of a not nice person. Medication side effects. A lot of people, because side effects aren't like you take a pill and you feel the side effect, a lot of people don't necessarily attribute what's going on to side effects of medication. So ask them about, have they changed their medications or adjusted their medications? And even if they haven't, a lot of medications are sensitive to age. So if they're taking it and their liver's not clearing it fast enough, especially true in a geriatric population, dehydration, and other things that they may be taking, whether it be herbs or alcohol or whatever. So ask them, well, since you noticed this happening, has anything been different? Have you started taking any medications? Even if they haven't, ask them what medications they're on and look at the side effects. A lot of people don't realize that things like Zoloft, if you miss a dose or if you're late on your dose, you may start feeling like you've got flu-like symptoms. They don't realize how important it is to take it pretty close to when you're supposed to take it every day. Informed consent. Checking in. Don't assume you know the cause. Look for multiple reasons and then talk it out with the patient, because they're the expert on them. Medical errors can be defined as diagnostic errors, which is an error or delay in diagnosis, failure to employ indicated tests. You're just assuming, yeah, that's probably what's going on, so I'll throw this medication at it or this treatment at it. Use of outdated tests and therapy, or failure to act on results of monitoring or testing. This is one of those things that's true in substance abuse treatment. If you fail to act on positive drug screens, or if you fail to address when you know somebody has been cheating a drug screen because it comes back either diluted or it's a guy and he comes back pregnant. These are problems that need to be addressed because it indicates that the symptoms are probably worsening. So there needs to be a change in treatment. Treatment errors include errors in the performance of an operation, procedure, or test. If you're trying to do something that you're not well trained for, don't do it. But for example, if you are ineffective at EMDR, or if you're using dialectical behavior therapy and you're not employing all the tools, or you only know enough about it to be dangerous, could cause a medical error. Avoidable delay in treatment or in responding to an abnormal test because you're behind on your paperwork, because your caseload is too large. For whatever reason, you find this test coming up and you don't do anything about it because you don't know about it, because you didn't bother to read it. Inappropriate or not indicated care by type. If somebody has a mental health issue and they're mental health primary, and you put them in a substance abuse primary facility, most facilities are not truly co-occurring enhanced. They're going to more heavily treat one or the other aspect. That can be a medical error. I've seen it happen a lot, and I've seen a lot of mental health patients walk out and go, yeah, I drank every once in a while to make the pain stop, but I don't understand what they're talking about, because they're not relating it to mental health. Intensity, we already talked about that. If you put somebody in too low or too high of an intensity, you're setting them up for failure. Breadth and diversity of treatment if you're putting them in this single focus of treatment where it's just talk therapy. Or worse yet, it's just individual group therapy. And the person has social phobia. I don't know. I'm reaching here. But you want to look at something that addresses the biopsychosocial needs of the patient. And duration. If you tell somebody they're going to be in treatment for 8 weeks or 10 weeks, that's one thing. But if you keep a patient in treatment for 8 years or 10 years, it's fostering dependency. Most likely, they either haven't benefited from your treatment and you're just kind of stringing them along, or something else is going on, and you may need to refer out. But it's important to empower clients to take a break from treatment, experience positive effects, and have multiple short episodes of care instead of being in treatment their whole life. Prevention. Failure to consider multiple causes of symptoms. If you've got a patient who comes in and says, I'll use the thyroid example again, that they feel exhausted all the time, their hair is falling out, they're in their 30s and they're starting to get acne like they were when they were a teenager, it's probably a clue that something physical is going on. So it would be good to refer to a medical doctor at that point, just to take a look. In that particular case, you may have something going on with hormones, polycystic ovarian syndrome, could be thyroid. Let the medical professionals work that out and hopefully communicate with you. Failure to provide preventative treatment. If somebody comes into your office and starts telling you that they are prescribed an antipsychotic and they're drinking a fifth of vodka every night, well, I guess that's kind of intervention. We want to educate them that that's not okay before they start taking the antipsychotic. But then if you find out that they're doing that, intervening before they end up in the ER is going to be really important. And figuring out how you're going to do that. Consult with colleagues, consult with your legal team about the exact procedures. It happens a lot, so expect it. Inadequate monitoring or follow-up of treatment. Another one of my pet peeves is discharging somebody from residential and saying, okay, go to meetings, good luck. That's like taking somebody who has been in military boarding school through all of high school and then sending them on a backpacking trip in Europe. Hello? Don't expect them to be at their very best because those are skills that they don't have right now. That's too much of a change. So following up, making sure to refer to aftercare, provide them options, provide them connections, make sure they have adequate support. It may not be treatment with your agency. They may only want to go to meetings, but make sure they know how to reach out for support if they decide they need more than meetings. Failure of communication, equipment failure, or other system failure, especially if we're talking about electronic health records. This can cause medical errors because if you don't have access to the patient's record, it's hard to do your documentation, which causes communication errors, and you see where we're going from here. Make sure your agency has redundant backups of all your electronic health records that are backed up, preferably in real time, not at the end of the day, because a lot of stuff can happen in 24 hours that will get lost. Symptoms requiring immediate attention. Suicidal or homicidal feelings. Okay, I hope we knew that one already. Sudden severe pain anywhere. And I don't mean like, oh, I've got a really bad headache. I mean like debilitating, bring you to your knees, pain. Generally, get the person to a place where they're safe and get them assessed, because that's not normal. Uncontrolled vomiting, not normal. And you're probably not going to want to keep the person in your office anyway, so medical referral. Head or spine injury. We typically think of this like car accident. But if somebody falls down and bumps their noggin on the coffee table in your waiting room, and they have this big old goose egg, probably a good idea to at least get them looked at to make sure they don't have a concussion. Bleeding that won't stop. Again, hopefully we had that one already. Swallowing a poison. And a poison should be pretty broadly diagnosed. In residential, we would have people that would eat or drink the hand sanitizer because they couldn't get to any other alcohol. It's a poison. Especially in co-occurring and drug treatment facilities, being very conscious of what substances that somebody could ingest. You may not know what they ingested, but when they pass out and they've got a weird smell in their breath, you can get an idea. Cool, clammy, pale skin, sudden changes in consciousness. Those are all general symptoms that should say, I think we need a medical assessment like now. Tuberculosis, we need to screen for it, and if we see any of these signs, refer for medical treatment immediately. Coughing up blood, persistent night sweats, unexplained fever, a cough for the greater than a month. Those are all things we want to rule out. Heart attack, chest pains, dizziness, weakness, irregular pulse, fatigue for days, shortness of breath. Yes, a lot of these symptoms are very, very similar to a panic attack. Are you qualified to make that call? Probably not. So it's always a good idea if you've got a patient experiencing these symptoms to get a medical assessment. Stroke, difficulty seeing out of one or both eyes. They start getting blurry vision. Difficulty walking. Numbness or paralysis in the face, arm, or leg. Numbness or paralysis anywhere except for, like, if they know they have carpal tunnel and their fingers go numb sometimes, probably needs to be checked out. But if it's sudden and it's over a big body part, immediate medical attention. If they have difficulty speaking or understanding suddenly, some people just don't speak clearly, but if all of a sudden someone starts slurring their words or doesn't seem to really understand what you're saying, really important to get them medically cleared immediately. So let's talk about prevention really quick. You need to have a single point of contact. You should have procedures for conducting and reviewing assessments and clinical histories to make sure they're thorough. All of us, at one time or another, have been guilty of being a little lax because we were in a hurry, we were tired, we were distracted. Those aren't good things. We shoot to never be any of those, but reality. So we need to make sure that there's somebody that is the check and balance person that says, ooh, you were having an off day that day. There should be a policy for communication with team members and referral sources. How often do you call the general practitioner? How often do you communicate with the psychiatrist? At minimum. Some doctors or psychiatrists will say, oh, I need you to fax me something every week. Been there, done that. A general policy for the minimum communication, obviously with people for whom you have releases of information. Multidisciplinary policy regarding abbreviations in the clinical record. Make sure everybody can understand it. If you're using the abbreviation HX to mean history, make sure everybody understands that's what it means. Worst case scenario, have a key in the front that any abbreviations are listed on. Make sure you have clear and informed consent procedures and they're regularly audited to make sure they're being followed. Comprehensive, non-punitive risk management and incident reporting policies. The majority of people out there, and I would say 99.999999996, don't ever try to harm anybody. And when something happens, you feel bad and it's an accident, but if people are afraid they're going to get fired or written up, they're less likely to report it. So if there is a non-punitive risk management procedure, that helps a lot. Now, if they were sleeping on the job, that's one thing. that you may need to address it from a performance standpoint, but you definitely have to tread lightly on how you address different things in order to make sure that people aren't going to not report things for fear of retribution. Mutual respect and open communication with teams. Goes without saying, if one team feels like they're not appreciated or respected, they may just feel like, well, my opinion doesn't matter, so why should I bother? Make sure everybody feels like they're part of the team. Annual staff training on signs of medical emergencies and emergency procedures. This isn't just your annual basic life safety course. You need to go over the signs of stroke, the signs of heart attack, and kind of what to do. Preferably role play it. Look at scenarios that have happened on your unit. Pain assessment, medical errors related to pain management and the impact of pain on biopsychosocial treatment. Remind people that it may be a pain to assess pain, but pain can negatively impact the cognitive and the psychological part of the treatment that you're trying to do. Make sure staff is aware of signs of addiction and substance impairment. They know that if the client comes in and their pupils are like, minuscule and non-reactive, there's probably something going on. This is important because if our client starts self-medicating, that's probably the first thing you're going to notice is changes in behavior, changes in pupils, itchiness, irritability, agitation that you can ask the patient about, and obviously look for in a drug test if needed. Regular supervision, it keeps us all on our toes. Without, having to be held accountable or whatever you want to call it, it's easy to get lazy and start taking shortcuts. So regular supervision, even if it's just between colleagues, is super helpful. But if it's with your supervisor, it's even more helpful because, that person has a certain amount of power and authority. Reasonable caseloads. I can dream. I can dream. Many states have caseload limits in their statutes. So it's important that you know what your caseload limits are if your state does that. I know Florida does, and they limit caseloads to certain sizes. Now, what that exactly means, what an active patient is, sometimes is up for interpretation. Hopefully, you've got a good supervisor who can advocate for you and really look at some of the benefits. I know, again, in Florida, which is where I spent most of my career, there's a lot of emphasis on outcomes now. So it's less about how many people you see. It's about whether they stay in treatment and whether they're drug-free 30, 60, 90 days later, and multiple other biopsychosocial factors. So they're looking at your effectiveness and whether you help the patient. Go figure. So reasonable caseloads are becoming more the norm, but it's still not there. There's still a lot of pressure because of lots of regulatory reasons. And administrative policies that focus on the well-being of the client over profits and billable units. And this is where we as middle managers often find ourselves advocating for the clients and the staff because sometimes upper administration forgets about how much time it takes to do this, that, or the other. So keeping everything real. I had a supervisor that I was blessed to work with for 14 years who, if you asked him to, would do your job. I mean, not all the time. But if you said, this is not reasonable, he would try it. And most of the time, he would go, yeah, you're right. We need to make some changes here. He's also a man who would be in a three-piece suit, and he would drop somebody's urine just as soon as look at him, which, I give him a lot of credit because we did observe drops and feel bad for the people who had to stand in front of him and pee. But he didn't ask us to do anything that he wouldn't do, and he was willing to hear from the minions. And I think that really went a long way to supporting loyalty towards him and how good that program was. But anyway, so making sure you have administrative policies and administrators that really care about the patients. Root cause analysis. We're almost there. Just stick with me about another 5-10 minutes. It identifies the problem and its significance. What happened and why do we care? You want to identify the causative factors. The institutional or regulatory is what the state says, what Medicaid says. Like when Medicaid cut the funding and said people can only have case management if they meet these 7 criteria and the moon is blue on the 2nd Thursday of the month. Really? So that can lead to problems that you've got to figure out how to adjust to, because a lot of times you can't change that. But understanding how regulatory changes impact your patients and impact your program is really important. Organizational, emphasis on billable hours or census. Okay, we need to work on that. Businesses can't keep their doors open if they can't at least break even, and they really need to show a little bit of a profit so they have a cushion for the bad months. Making sure it's reasonable and figuring out how to use volunteers, figuring out how to use time as effectively as possible. Frequent changes in policy or procedure. If you can't keep up with what you're supposed to do when XYZ happens, then it's going to be really hard to make sure that you're doing the next right thing. Work environment, if it's chaotic, things are going on everywhere, you're running 6 different directions. I can't imagine working in an emergency department. That would drive me crazy. But I'm a little too structured and high-strung for that. But if you're working in a work environment that's chaotic, it may be easy to miss things if that's not what you're trained in and that's not what your temperament is. Some people thrive in it. Lack of role delineation. Somebody mentioned that in one of our other questions earlier, where you're a counselor. You counsel, you talk to people, you do treatment plans, behavior modification. We don't know anything about handing out medication, so lack of role delineation when we're asked to do things that are way outside of our scope and training can lead to problems. Making sure that when there are specialized roles, there are backup plans so people don't have to cross over and do things for which they're not trained. Burnout. I have a whole class on burnout work environments. But environments where people don't feel like they have a say and they don't feel like anything they do matters, where they feel like somebody's always sort of waiting for them to make a mistake, it's exhausting. And it takes away from the energy people have to spend focusing on patients. It can also make people make wrong decisions because they don't want to get in trouble. Team environment. If there's a lack of respect, poor communication, intimidation, all of these can lead to poor communication, medical errors, and sentinel incidents. So we need to address it. We want to look at staffing levels, education and expectations of the staff. Were they appropriate? If not, what needs to change? This is not to point the finger and go, oh, it's your fault. It's to look at the system as a whole and say, what could we do better? Where were we falling down? As they say, a chain is only as strong as its weakest link. Where are our weak links and how can we strengthen them? It's an educational process. Task-related, lack of safeguards, human error. The old-fashioned written prescriptions of a doctor, if you can't read a doctor's writing. Or in hospitals, when people used to manually figure out dosages or, heaven forbid, do it in their head, there's a lot more room for error than if you have a computerized app that tells you that for a 46-year-old male that weighs 184 pounds, he should have this dose. Lack of safeguards too, especially if somebody's in the hospital on multiple medications. There are a lot of programs now that will look at the medications the person is on and send up red flags for the doctor to assess if there are contraindications for different medications being taken together. Patient characteristics. concurrent conditions, what else they've got going on that may be making this worse. Biopsychosocial history, diagnosis. When we look at suicide attempts, we look at patient characteristics a lot, and we look and see what was it about this patient that we may have missed that we may see in other patients. What are some warning signs? Hindsight's always 20/20. What are some warning signs that we may have picked up on that we missed? Or how could we have handled this situation differently? And a lot of that is where we're moving into a biopsychosocial model and really looking at the physical, social, and psychological aspects. We want to identify the relationship between the causative factors and the problem. This is the problem. There are all these things that happen. Now, how do these influence and get us from point A to point B? It clearly identifies the evidence of the causative factors. We know this happened because we know people were afraid to report this situation because of this policy, and it happened a lot, and it became commonplace because of this other policy. We have evidence that it's happened in the past. Well, so we know we need to do something about it. It identifies solutions to correct or prevent further occurrence of the causative factors. What are we going to do to prevent it? Reviews the potential impacts on the solutions. All right, so if we make this change, what could the possible effects be? We know what we want them to be. But what are the possible negative effects? We decide on a course of action, and then we document the problem, the causes, our proposed solutions, and our relationship that we've identified between the cause and the solutions. This is the problem, and this is why we're doing this. If we give people a why, it helps them understand. Last question. What are some of the risk management procedures your agency currently has or should have in place, and what errors could they prevent? We'll spend about 3 minutes on this, and then the next slide is the summary. So I promise we're almost there. Electronic medical records error checking. So the EMR looking for contraindications in medication, looking for progress notes that aren't done. That way our communication isn't poor. Looking for or preventing abbreviations that nobody understands. Electronic prescriptions can be a sloppy handwriting fix. Oh yeah. I don't write prescriptions, but I have some sloppy old handwriting. So I really was happy when we went to EMRs because I can type a lot faster than I can write. Regular training and emergency procedures. What do you do if? It should be probably, I would love to see it as common as your fire drills. Once a quarter, just do a scenario. It can be in staff meeting, I don't care. Requirement for patients to be medically cleared by a physician before admitting to a residential program. That's huge. Let's rule out anything that may be going on that's significantly impacting this patient or could be contagious or detrimental to other patients on the facility. Screening for TB at assessment and making referrals as needed. Again, could be contagious. Let's make sure we get that underway. And that's law in most states. Let's see, any others? Now, if you put an answer in and I've already moved on, you're going to get credit for that. It gets recorded. But I'm going to go ahead and move on to our final. There we go. Don't let staff work too long straight. Yes. A double is really hard to do every once in a while, and it's almost impossible to do with quality on a regular basis. A triple, you can't do effectively. So don't even ask staff to work a triple. Decide on a course of action to prevent future errors and increase communication within the agency. Oh, once you do the root cause analysis, how about telling people about what's going to change? And make sure to have emergency plans handy. I like the old-fashioned 3-ring binder at the front desk as a backup. but I also like a searchable PDF on the intranet. Okay, again, you'll get credit for these. Have a doctor on call and actually reachable. Yes, you need to know what your medical backup is. And even if that means that you end up calling if there's a emergency number that you can call. Okay. In an integrated, comprehensive system of care, it's important to assure appropriate and effective documentation. That way everybody knows what's going on and we can check and balance. It prevents doctor shopping, prevents things from going unnoticed, but it also gives us a more comprehensive picture. Medical errors can occur in many settings: hospitals, clinics, individual counseling settings. So it's important to be aware and not just think because it says medical that it only applies to doctors and nurses. A medical error causes or has the potential to cause physical, psychological, social, or financial harm to a client and or his or her significant others. What they see, you know, that whole social learning thing, if you see somebody have a really bad experience, you may be like, oh no, I'm not going to do that. Medications can be both the solution and the cause of problems. Talk with your client. Ask them what's working and what's not. Professionals must be aware of the signs of medical emergencies and know how to intervene. A comprehensive risk management plan is essential to the prevention of medical errors. Have somebody go through and play devil's advocate and try to figure out all the different ways somebody could get hurt or decompensate or have a bad experience that leads to a sentinel event, and try to figure out how to prevent those. Talk with other agencies that have been in existence for a while if you're new. Generally, people are willing to talk about risk management plans. And make sure an effective root cause analysis examines the identifiable and preventable causes of problems. If there's no way to prevent it and no way to identify it, if you have a client that drives out of the parking lot and gets T-boned by a drunk driver, yeah, that sucks. But that was not identifiable or preventable on your part. So a root cause analysis is not going to do a lot of good unless you want to try to petition for a stoplight. So use good common sense. Medical errors can be prevented with just our general best practices. And so I thank you for joining me tonight, and I hope to see you again next Wednesday.